Welcome, everyone. I'm thrilled to welcome you to the first IMA Team 3 Town Hall. My name is Susan Edgman-Levitan, and I'm the Executive Director of the Stoeckel Center for Primary Care Innovation. We are so happy you could join us today, and it's wonderful to see so many familiar faces. Before we get started, I need to share a few housekeeping rules so that everything goes well with the town hall. We're all getting used to all this Zooming we're doing. So all of the participants, except for the speaker, will be muted to avoid any background noise or distractions. You can view the speaker on your full screen, or if you go up to the corner of the screen of the Zoom, there's a little square box, and if you click that, you'll just see the speaker. And then you can go back to what is called the gallery view, which I think many of us have now. If your picture becomes jumpy or out of sync, which sometimes happen when we have a lot of people on a Zoom call, you can turn your video off. And if we really notice it, we may turn all the video off as well to improve the quality of the call. For questions, which we'll have time for the last 20 minutes or so, please use the chat function. If you go down to the middle of the screen at the bottom, you'll see chat. And if you click on everyone, you can send your questions in, and I will be teeing them up for the different speakers depending on the nature of the question. We won't be able to get to all questions today, but we'll do our best. The other thing I want to remind people about is because we can see everybody and anything you write in the chat can be read by everyone, please don't write any personal medical information, and please don't send pictures or anything like that, because you'll be sharing it with everyone on the call. But if you do have a medical question or concern, we really encourage you to reach out to your doctor or to the practice. We did get a lot of questions before the town hall a couple of weeks ago, and so we framed the presentations to try to address most of them. We have a lot of great speakers today, so I want to get started, but I also want to let you know that because we want to leave time for questions from you, if any of our speakers tend to go on a little bit longer, I may have to step in, but I'm really not intentionally trying to be rude. So to get us started, and I'm going to introduce all the speakers, and each speaker will just hand it off to the next person. So we'll first be hearing from Dr. Blair Fosberg, who's the Medical Director for Internal Medical Associates. Then we'll be hearing from Dr. Bill Kormos, who is the Team Lead and Director for the Team 3 group within the Internal Medical Associates. Then we're going to be hearing from Lee Simmons, Dr. Lee Simmons, who's also a physician on Team 3 in the IMA. And then we'll hear from Juliet Jacobson. Dr. Jacobson is the Medical Director for the Continuum Project, which is part of the work that we do in palliative care at Mass General. So with that, I'm going to turn it over to Dr. Fosberg to get us started. Blair, we need to unmute you.
There we go. Thank you, Susan. It's nice to see some familiar faces out there. I want to join Susan in welcoming all of you. I'm glad you could join us today. And I want to start by just acknowledging that this is a scary and unsettling time. I hope you are all being careful and staying safe and healthy. I will say that I feel very fortunate to be at MGH, where we have wonderful leadership and where everybody in the clinical and research realm is working incredibly hard to both take care of patients, but also try to figure out the best way to treat and hopefully ultimately prevent this disease. And I hope that you all take some comfort in being part of this community as well. I wanted to start off by just telling you a little bit about what's going on here in the IMA. First of all, we miss you. We do not like having empty halls and empty exam rooms. We go into this because we like seeing people. And although I will be singing the praises of virtual visits going in a little bit. It is not the same as seeing people in person, so we miss you. Although our halls are somewhat empty, we have not been idle. We have really had to change the way this practice works completely in a very short period of time. And we're going to have to keep doing that for the foreseeable future. So it's been a time of a lot of change around here. Some of what's been happening is we've had to figure out how to keep our staff safe. We've had to figure out how to have some of our staff working from home. You may not even realize it, but sometimes when you're calling the office, you are talking to someone who's actually working remotely. Many of our staff have been working on the inpatient floors. They have been working in the respiratory clinics. They have been working in the isolation hotels that have been set up. We have been doing hundreds of outreach calls to patients with respiratory symptoms. Many of you may know and may have read in the press that people can have symptoms of COVID and be doing okay for a while, and then after a week start to get much sicker. So we are doing outreach calls really until people are well, regardless of what the test results showed if they were tested, or even if they weren't tested at all. So we've been doing a lot of outreach to patients. We have also been doing a lot of virtual care, and then as needed urgent in-person care. We are incredibly grateful for all of our staff and clinicians who have really stepped up in this situation and have been doing amazing work. As the surge starts to pass, we're starting to have some of our staff come back to us who had been redeployed elsewhere. And that brings me sort of to next steps. What's going to be, how are we going to go back to business as usual? Well, I think all of you know that business as usual is not going to be returning, will be slow to return everywhere. And I want to emphasize, of course, we are open. We are here for virtual care. We are here at the phone if you need us, and we're also here for urgent visits. The leadership of the hospital is actively talking right now about how we safely move to start bringing people back into the practice. And we will probably be first looking at folks with chronic medical issues who really do need to be seen in person and trying to get them in. We will be figuring out how to keep the practice and patients and staff safe with physical distancing within the practice, with staggering schedules, with interspersing in-person visits with virtual care and so forth. There's a lot happening here and things are changing quickly. When we move to this next step will depend largely on Governor Baker's recommendations in the coming weeks. But we are, a lot of people are thinking very carefully about how to keep things safe and make the transition back to care that has happened previously a safe one, and a smooth one. So I lastly want to reiterate again that we are here, we are not closed, and I will now turn it over to Dr. Kormos.
Thank you, Blair. Once again, I will share my welcome and hello to familiar faces and to everyone. Hope everyone is doing well. As Blair said, we are doing well here. We are, as you can tell, in separate office rooms. We are carrying our masks around, so you know, we're role modeling what we say. You know, it is unsettling times. There's a lot of concern and anxiety. I've been asked to provide a little bit of information on some of the questions that you submitted around transmission, as well as some of the testing questions that have come up. I don't expect that I'll answer everyone's questions or everyone's particular situations, but just to give you some general info of what we've been sharing with people and what we have discussed with our infectious disease experts here at the hospital. So before I get into that, I do want to emphasize one part. This is, you know, very nerve-wracking for a lot of people, and everyone's kind of been concerned with what's going on. But most of the patients that we are seeing in the hospital and in the outpatient clinics are doing well. So most people recover from this. Most people do not need to be hospitalized. Currently, we probably only hospitalize about 10% of our patients diagnosed, including those in the high risk and older groups. Those hospitalizations have been going down over the past 2 weeks. We've decreased from our peak by now about 50% of our peak, and that continues to go down at Mass General. So as Dr. Fosberg was saying, kind of getting back to more normal operations here at the hospital. The cases sort of out in the community have also been declining, but at a slower rate. But the percentage of people testing positive now does seem to be decreasing, which could be a sign of increased testing capacity, but it also does seem to reflect decreased infection in the community. I'll first talk a little bit about transmission, which a lot of people obviously are concerned about. You've probably heard that after you potentially have had an exposure or you were at a place where you were concerned with an exposure, that you would quarantine or isolate yourself for 14 days. The reason for that is that although the average time from an exposure to the virus to actually developing illness is about 5 days, there are some people that might take 10 to 14 days before they develop symptoms. And so really after that 14 days, if you've been exposed, it's unlikely you're going to get ill after that. But then people sort of talk about, well, what about this asymptomatic shedding we've been hearing about? This is where you're carrying the virus, but you're not showing any symptoms. How often does that happen? How long can that last? We don't know a lot of details about that because it's obviously harder to study. Most of what we know is from people who have actually gotten sick with the virus. People are considered to be less infectious after they've been ill after about 7 to 10 days when they've been symptom-free for a number of days. However, we've tested people repeatedly who've had the virus, and their virus test may stay positive for 30 to 35 days after their illness. It is not clear that that's still infectious, and it's thought that the contagiousness of the virus really does drop considerably after that first week. It's not the standard for people who've been sick to then get tested to see if they're now negative, because as I said, it's not clear that that's significant or important. There are some occupations, including healthcare workers, where they do require you to test negative multiple times before you would return to work. So that's the situation in people who we know have been sick, but what about asymptomatic people? The reports on this really have varied widely on the incidence of asymptomatic carriers. I think the challenge here is how it's defined. Many of the people that are defined as asymptomatic in those studies are actually pre-symptomatic. In other words, they're about to get sick in 2 to 3 days, but at the time the study was done, they were reporting to the person doing the study they had no symptoms. So it seems like there is this shedding that occurs a few days before you get sick, which is one of the concerns, but to actually stay asymptomatic is relatively uncommon, and most people do not do that. So that seems like it's less likely, and it also seems like you're probably less contagious, and once again, after 7 to 10 days, seems like it's probably less of a concern. So people wonder, should we just test everyone for the virus to find out who's carrying it? The problem with that is that the current test of the nasopharyngeal swab you've heard so much about, where they push the swab back into the back of your nose, is not perfect. It can miss 20 to 30% of people with infection. And so even a negative test isn't a complete guarantee. And also, the idea of testing everyone at this point, we just don't have the capacity and number of tests to do that consistently. We are screening all our hospital admissions. We are, regardless of what you come in for, we are screening all our outpatient surgery patients, and the number of people that we're finding that are carrying the virus without knowing it seems to be pretty rare at this point. So that's why the kind of universal masks, the social distancing, the hand washing is always going to be recommended regardless of that testing, because people may get sick in a few days even though they don't feel sick at the time. Some people have asked about, well, what happens if I've been self-isolating, not exposed to anyone, and a family member in a different household is self-isolating, not exposed to anyone, and it's been weeks and weeks have gone by? Is it safe for us to get together? It depends, I guess, on how well that isolation truly can happen. And every time that you're potentially exposed, the clock may have to restart. But it certainly seems that that kind of isolation does lower the potential risk to transmit it to other people. We just can't say it's zero. The other thing that I'd like to sort of just address is the testing part for antibody testing, which has gotten a lot of interest. And in the news, there's been a lot of talk about this being the mechanism that we're going to reopen the economy with, that this is going to give people immunity passes. So the reality of it, unfortunately, is that this is really not ready for prime time or routine use. It's probably not going to be the best way that we're going to achieve these. You've probably seen some research studies looking at the community prevalence of antibodies in a certain community and heard that reported. For a large population, that's probably a good way to study things and study trends and changes. But for an individual person to make a decision based on an antibody test is a little bit harder to interpret at this time. So the reason people might want their antibodies tested are two: just they're wondering if they had the infection, wondering if that illness they had before was in fact coronavirus illness, and whether or not that infection would then give them some immunity. So I'll just address those kind of two questions. First is, we've been hearing from a lot of people saying that they were sick in January and February before we were testing people, and wondering if that was the earliest case we were seeing of coronavirus. Can't say that it wasn't, but there also was a lot of influenza A prevalent in the community at that time. So a lot of that viral illness was most likely not. The antibody tests that are available are not really well studied at this time. You'll keep on seeing reports, you'll keep on seeing press releases of companies promoting their test. These are on relatively small groups of patients, very selected patients, which can really make a test look much better than it is. When you first test some things, you can usually get exact populations that you want, and your test usually looks much better. When it's put into larger studies and larger populations, the characteristics of the test tend to perform less well. So we're not that confident on the accuracy of the test. We're not that confident on the data. And if we start doing inaccurate tests on people, we're more likely to give you a wrong answer than a right answer. And that might be even more dangerous for us to tell people they have a positive antibody when in fact it's a false positive or not a true test. The other follow-up is, well, if I had the antibody and it was a true test, how we would know that would be hard, as I just said, but does it mean you have immunity? And that is just not known at this time. We know that there's some viruses like measles that having the illness and then having a positive antibody and having a positive test gives you lifelong immunity to that illness. But we also know that something like influenza does not do that, and we don't check influenza antibodies on people to see if they're exposed. And we just don't know where this virus is going to fall in that spectrum at this point. We're just not quite sure how long the immunity is and how strong it would be. Many of the tests that are coming out early are qualitative tests, yes or no answers to an antibody. And that also kind of goes against how we often test antibodies, which is by titers or strength of response, which is a better way to measure your actual immunity to a particular disease. So to summarize that, for the antibody testing, we don't have a lot of detailed information about the accuracy of testing. We don't have evidence if immunity follows a positive antibody. And so therefore, at this time, we are recommending not to routinely test for antibodies. So when would we? When's that coming? It's hard to tell. The Center for Disease Control is trying to validate their own test and putting out some reference standards. And then studies are probably going to follow in the next few months after that. So it certainly is a little bit away before I think we would think we have some confidence. And then I think the next sort of step would be, really what is the value of doing that versus other strategies to try to decrease the spread and transmission. So that's all I sort of have for now. I'm sure we'll have some questions that come up at the end we'll try to answer. But at this point, I'm going to turn it over to Dr. Simmons.
All right, thank you, Bill. And it's so nice to see so many familiar faces, and we welcome you to this first town hall. I've been asked to speak briefly about why it's so important to get care when you need it. And I, in my practice, have switched over 90% of my patient care interactions to being virtual, either by telephone or by a video visit using a technology like Zoom. And I've been really thrilled to find out that that has worked extremely well to stay in touch with my patients and for me to hear their concerns. And for those of you who've done virtual visits with your doctors, you may have found, I certainly have, that the visits lasted a little longer maybe than even the office visits. It was much more time with me and my patient. There was not a lot of running around the office and getting things checked on, and a lot of wait time. Everything was really efficient, and time with patients. Dr. Fosberg's going to talk a little bit more about how to do those virtual visits really efficiently. What I'm going to speak about is, what about when we can't do those, and that 10% of time, for example, that we can't. And so the first thing I would say is, it's very important that you and your doctor make a decision about whether your visit can be done over the telephone or with video, or do you need to come in. And I will say that though many people have said it would really be better if I could see you in person, because I'd like to, remember that if you choose to make your visit a virtual visit, you've decreased the density on the MBTA. You've decreased the density in the parking lot. You've also made it a safer experience for other patients who absolutely have to come into the office, because you won't have to be there in the waiting room awaiting your doctor's visit if you think you can do it more, you think you can do it by video or phone. So please remember that when you're making that decision with your doctor. So what can't be done virtually, and how can we do that safely for you? There are some things like diagnostic studies, a CT scan, an X-ray. Right now, we don't have good ways to do any of that from coming into the home or home technology. So you may be sent by your doctor to go to one of our outlying facilities for one of those radiology studies, or even into Mass General. That does not necessarily mean that you needed an office visit with your doctor. I've had plenty of patients for whom we've made a decision that, yes, I really do need to check a CT scan to see if you have a kidney stone, for example, but you don't have to come into my office for an examination. I want you to go straight to the radiology center, have your scan, and then we'll talk afterward. You may also similarly be sent for blood testing. And many of our laboratories at various hospitals are making it very easy for you to say, wait in the car, and they'll call you in. They have the technician ready, so that there's very minimal time in a waiting room. And you're not surrounded by other people. You're in your own vehicle until you can go get your blood test done. So keep those options in mind when you're talking about coming in for care. Other things that are going to be more difficult to evaluate just by telephone or video. Sometimes there will be, say, I'm having a lot of trouble actually looking at rashes. People send me pictures of rashes or want to look at that by video. You can tell even here, it's not the clearest detail. It's kind of hard to see things closely. So your doctor might say, you know what, I'm going to have you come into our office to look at that, rather than looking at this all over the phone or by pictures. So keep those things in mind, things that we just can't see as well. We may ask you to come on in. What else, when else might you want to come in to see the doctor directly? There may be some conditions that you and your doctor have decided really do need that follow-up in-person visit, and those will be negotiated individually. In many cases, though, there are disease conditions like high blood pressure, diabetes management, that you and your doctor can set a schedule where you'll check in and send things in by patient gateway, for example, by regular telephone call. And that actually can spare that in-person visit. Really important to stay on top of those conditions. We don't want things to go by the wayside. The coronavirus pandemic is going to affect how we deliver care efficiently and effectively and manage our patient population. But we can mitigate that by staying on top of a good schedule. So if you have a condition that requires regular monitoring and you haven't set up a regular way to communicate with your doctor yet, please do so after this call. Reach out to your doctor and set up a schedule where you'll be checking in, just to make sure things don't fall through the cracks. I do strongly recommend that. Many people wonder, how are we making sure that Mass General is safe for patients to come in? during this time. And the processes for regular cleanings and reducing density in the office are all being developed. Those have been in place quite well for the reduced number of employees and patients we have right now. We have somewhere around 10 to 15% of our usual patient volume in our offices these days. That's across the hospital. But how are we going to do that when we're up to larger numbers? Those processes are being worked out now by infection control. And you will probably notice some differences when you do come here for blood testing or radiology studies or for your first visit back in the office. Right now, we're asking everybody who comes in to wear a mask and do hand sanitizing. All staff are doing that very regularly. You would not believe how much hand washing and hand sanitizing happens for all of us regularly, and that'll be something you're asked to do. Those are the processes now. That may change in the coming months as we watch carefully on the levels of coronavirus infection. So just be ready for changing policies. It's not that we're inconsistent, it's that we're responding to the level of disease in the community. So there'll be plenty more to come on that, and we'll keep our patients updated in ways like this town hall. Susan, I'm going to ask, I'm not sure if I turn yet to Dr. Fosberg or to Dr. Jacobson. Do you know who's yet next?
Dr. Jacobson.
Okay, so I will turn over to Juliet Jacobson, and thank you.
Wonderful. Thank you, Lee. So I'm going to be talking for a few minutes about what to expect if you are hospitalized, and also the importance of these matters most conversations. So I am a palliative care doctor. I'm also an educator. I've been at Mass General almost 15 years now. And before this pandemic, one of my big roles was actually to teach clinicians throughout the hospital in primary care and in oncology how to talk with patients and families about their values and goals for their care if they did get sicker. And so I did a lot of training, and we often used actors because clinicians aren't always comfortable having these conversations. And then when the pandemic happened, we just needed to have lots of conversations. And so my job changed a little bit in that I went down to the emergency room, actually with a team of palliative care doctors, and we spoke directly with patients, having these conversations about what their priorities would be for their healthcare. And the way this worked, I would get a referral from an emergency room doctor for someone who might have the coronavirus, and I would call their PCP and get a little bit of a sense of their health and what had been going on. And then I would gear up. You wear one mask and you wear another, like shield and a hat and gloves and a gown. And I would go into rooms with patients to talk with them about the what ifs, about what if they got sicker. And sometimes it was just me and a patient. And sometimes I learned over time, my phone, which just broke the other day, I'm not quite sure what to do, I have to get another one, but it was with me all the time. And I learned to call the families and we would talk together. And I actually learned to use the video so we could see the family members. And the craziest one I did, I was with a patient, me, the patient's husband on the phone, her PCP on the phone, and we needed a Spanish interpreter also on the phone. So it was kind of all of us together in this room talking about what to do if she got sicker. And so I'm going to talk with you for a little bit about what I said to patients in that situation. And it's a little bit like what Bill was saying. What I said is most people who get the coronavirus do okay. Most people have mild disease. And as you know, a few people get very, very sick. And I always hoped with my patients that they would be ones who would have mild disease. Even patients who are hospitalized, many patients who are hospitalized have mild disease. But we did make a plan about the what ifs to prepare a little bit in case they got very sick. And I would say there's two parts to making that plan. The first part is having a healthcare decision maker or a healthcare proxy who knows your wishes and what you would want if you got sick. And so choosing that person is the first step. And actually, in these times, we've changed our recommendations. We now ask people to pick 2 healthcare decision makers, just in case the person that you maybe see the most also gets sick when you get sick. So having that person and knowing who that person is very important. But what happens when we need to talk to that person is we don't ask that person to decide what to do. What we say is, you know your loved one best. If they were sitting here, right here with us now, what would they say? We ask the healthcare decision maker to tell us what you would say if you could talk, as a way to have you included in your healthcare decision making. And so for that reason, it's very important that you not only choose who that person would be, but also talk with that person about what your values and your wishes and your priorities would be in that type of situation. Because I'll tell you, one of the hardest conversations I have is when I'm sitting down with a healthcare decision maker and I say, you know, what do you think Mrs. Jones would say if she could talk with us now and tell us? And they say, I don't know, we never talked about it. And that happens a lot. So the first part is choosing the healthcare decision maker. And the second part is the hard part. It's sitting down and having a conversation, maybe a couple conversations with them about what your wishes might be. I will confess that this is hard even for me. And I always think this is my job. And yet somehow I waited a really, really, really long time to talk to my own father about this. These conversations feel hard and they feel tender. And it's very, very normal to want to put them off. But if you feel like you need to have a conversation, and I'll say people who are at higher risk are people who are older, you know, people who are over 70 and then over 80 are at higher risk to get very sick. Or if you're someone who has medical conditions in addition to age, that's another risk factor. And so if you're feeling like you're ready to have a conversation, I'll just tell you a little bit about how we do this, about how we train clinicians to have these conversations. And that's to sit down and think with your family and your loved ones about what would be most important to you if you were very sick. And most people have lots of things that are most important. Many people want to spend time with family. They want to maintain independence. They don't want to be a burden. They want to die peacefully. They want to fight as long as they can. Lots of people have many different, sometimes contradictory priorities for their health. But it's helpful to have some sense of what those are and to share those with your healthcare decision maker. What we've learned about this type of decision making is that healthcare has gotten so complex and the decisions are really unknown. We don't know for each person what the decision is going to be, what their medical condition is going to change into, what might happen. And so it's impossible to sit down and say, these are all the things that I want or I don't want. It's too complicated. What we need is to get some sense of your values and your priorities so that those can help guide care when we need to make complex decisions. So having some sense of that helps. One of the questions I like that really gets at that a little bit is this question of how much are you willing to go through for the possibility of having more time? We know with the coronavirus that some people who get sick need to be intubated, and thinking to yourself, is that something I'm willing to go through? And how long would I be willing to go through that? Maybe a few weeks. If it required months of intubation, is that something I'd be willing to go through? Having some sense, you don't have to know all of it, but thinking about it a little bit for yourself, knowing your own health and knowing your own reserve. Another helpful question is thinking about what abilities are so important to me that I can't imagine living without them. I asked somebody this recently and she was so cute. She was like, I've got to drive to see my daughters, right? And so there are these things that are a part of who we are and a part of our world. And this is so complex because people adapt and they change. And I was thinking, I bet even if you couldn't drive, you'd still want to go through a lot, right? Because there's things that we love having, and then there's things that maybe we just couldn't live if we lost. And so having some sense of what those are is helpful. Something that comes up for us when we're helping to coach families through some of the decision making is thinking about if your loved one had to go through a long sickness and then was very, very weak afterwards and lost their independence. If you had to be in a nursing home or you had to have a lot of help, would that feel worth it? And so kind of thinking about that trade-off for yourself. And then lastly, thinking if you know already, if there's some kinds of medical care that you just don't want. Some common things that people tell me is they would never want a feeding tube, or they would never want to be kept alive on a machine if they weren't themselves. If they lost their ability to think and interact, then that wouldn't feel worth it to them. So thinking through some of those choices. And I want to close by emphasizing that the real reason to have these conversations and think about what matters most, it's not only to clarify what might happen if you get very sick, although that is important, but it's also really to think a little bit more deeply about how we all want to live. When we ask patients to reflect on their health and think about their values, I think what we're really saying as clinicians is that time is precious and that it's worth really thinking about what's important. I'm going to leave us with a quote from Viktor Frankl, who said, "Life is not primarily a quest for pleasure or a quest for power, but a quest for meaning. And the greatest task for any person is to find meaning in his or her life." Okay. I think I'm going to be passing it over to Blair.
Yes, thank you, Juliet.
So we are going from a very lofty topic now back to something very nuts and bolts and practical, which was just a little bit about why and how to do a virtual visit with your doctor or nurse practitioner. And the first thing, again, I want to say is we are fully open for doing virtual visits, virtual care. We've been doing a lot of it. And so what's the difference between just like asking someone to call you back versus scheduling a set appointment for either a video visit or a telephone visit? I think the biggest difference is that the doctor or nurse practitioner has a block of time set aside just for you. And most of us, when we are seeing patients, we prepare ahead of time for that visit. And so if it is a scheduled visit, we anticipate it and we can prepare for it and make sure we're caught up on anything that might have happened to you in the medical realm since we last touched base. So that sometimes people say, well, if I can just do a telephone call anytime, what's the difference between that and a visit? And I would say that's it. It's planning and really having a block of time that's set aside just for you. If you would like to have one, obviously call the office or request through Patient Gateway. Some of you may have noticed that you used to be able to schedule an appointment online yourselves. We had just been starting to turn on that technology. With the pandemic, we really had to turn it off because we had to put in place a mechanism for screening for symptoms for everybody who's coming into the practice. So we had to turn that off temporarily. It will come back eventually. I also want to sort of reflect on, from my perspective, the value of a video visit over phone call. And it's, much can be accomplished either way. As I said in the beginning, we miss seeing all of you. And given that we're spending so much time on the phone, whenever I have a video visit, it's just such a pleasure to see the person's face. And you all have clearly passed the hurdle needed in order to be able to do one. You need a computer or a cell phone or a tablet. But we know not everybody has that capability. And so phone calls are absolutely still an option. you can see a lot just in someone's face and someone's body language. And so it really can add, I think, to the visit. And although, as Lee pointed out, you can't see a rash as well as you would in person, there are a number of things you can see, and so you can even do a limited physical exam. I will point out that we have neurologists here who've been doing virtual visits for a long time, and they will do follow-up neurologic exams and ask people to lift their arm up or whatever it may be. So they've been doing that for a long time. One silver lining from this pandemic is that I think telemedicine is here to stay. We had sort of dabbled in it, but now it is here to stay, and it will be an option for you going forward, which I think will be a great convenience to many of you, because much of what we do really can be done virtually and doesn't always require you to drive to MGH and to navigate the parking garage and pay the parking fee and sit in the waiting room and all that. So it will be here to stay. In terms of preparing for the visit, like any other visit that you would prepare for, think about what you want to discuss with your provider. It's also really convenient when people are home having these visits, because you can have your medications handy, and it's very easy to really do a good review of medications and make sure we're all on the same page about what any medicines that you might be taking. If you are able and have the capability within your own home, take your blood pressure beforehand, check your weight, check your pulse, things like that, so we can have some of those numbers available to us. And lastly, I think some people fear that if they have a telemedicine visit, that they won't be able to have an in-person visit. And I do want to emphasize that that's not the case at all. I think Lee mentioned this as well, that the telemedicine visit can help us determine when something is really necessary to happen in person. I just had this happen on Friday. I saw someone on as a telemedicine visit, and we decided that he really did need to come in, and so I saw him on Tuesday. So I don't feel that it's either or. It's definitely what's most appropriate for you. I want to add one thing on the safety in the hospital. Some of you may be aware of this, but I think this isn't something that maybe the general public knows. But every day when we come to the hospital, we have to first go onto our phone and fill out a symptom check. So we have to acknowledge that we have no symptoms, and then it flashes up, you are cleared to work today. And then we go through and we do our hand hygiene, we show our pass, we get our mask, and then we go to work. So all of the, some of the things that are going into place to keep things safe for you. So I think now I'm going to turn it over to Susan, who is going to sort of navigate any questions that people have. And unless I'm not seeing the full chat, I don't see a lot of questions in the chat. So people should feel free to be putting some questions in there.
Blair, thank you. One thing that you may have mentioned, but can you just make sure that people know how to schedule a virtual visit?
Yes, so either call the office or send a patient gateway saying that you, if you're on patient gateway, send a message saying that you'd like to schedule an appointment. The way patient gateway messages work, not everybody understands this, but they are triaged based on what you're asking for. And so if you have a clinical concern, I would always, there's a drop-down menu, and then like one of them is an appointment. That goes to the front desk. One is for referrals. That also goes to the front desk. Oftentimes people will have a clinical question and they will pick one of those two and it goes to the front desk, when really, it really should go to the nurse. All of the ones that are clinical, whether it's a visit follow-up or I can't remember the exact question of the drop-down, are those go straight to the nurse and then they forward them on to us. So
Thank you.
either one, phone call or patient gateway.
Thank you. And I also just have to say, I'm very glad that you mentioned the screening process that every single person that comes in to any of our practices or the hospital does every day, because I think a lot of people don't know that. We sent out the invitation for this town hall. We included some documents, And one is a document about community resources that may be helpful to you. The other one is a document that really talks a lot about what to expect if you have to come into the hospital and about how to sort of think about what matters most to you. And in that document, there are links to 2 resources that we have tested extensively with our clinicians, with our staff, and with many patient groups, called Prepare for Your Care, and the second one is called CAKE. You might want to take a look at those. They're different, but they have a lot of information, and actually Prepare for Your Care has lots of videos that help people think about a lot of the issues that Dr. Jacobson brought up in her presentation. So I just want to remind people that you have those. They're excellent, and Prepare for Your Care is actually available in English and Spanish. And what we often find is that people that start using these also start sharing them with their family and their friends, their children, their parents. And so I'd really encourage you to take a look at them. And they're all free and available to anyone. So a couple of questions that have come in. One question, and I'm not entirely sure, I think I know what the question is, but it's about what happens if you arrive in Boston from out of state. And I think I don't know whether you're talking about whether you need to self-isolate for a certain number of days or whether you can actually get scheduled for care or see a provider. So you may want to tell me a little bit more about your question. And while I'm waiting for that, we have a question about what if it's time for your mammogram? What should you do?
Radiology.
Oh, go ahead, Blair. Go ahead. Yeah.
Bill, you can jump in if you have additions. I think our radiology department has been recommending that routine radiologic studies they have not been having people come in for routine studies at this time. They are absolutely seeing people who need urgent studies, and how they will open back up to start to do routine imaging studies is sort of to be determined, but that is where we are right now. We are sort of at the point of figuring that out. So I suspect that they will start scheduling those again soon.
And what happens if it's time for your second shingles vaccine?
Yeah, that's a tough one. We've been getting that a lot. Our general recommendation is that you not come into the hospital for that because, again, you know, thinking back to some of the things that Lee mentioned about transportation and just density of people. The other hesitation I have about doing the second shingles shot is sometimes people get muscle aches and a low-grade fever, and then you're going to be confused about, oh, do I have symptoms related to COVID? There is a schedule for the shingles vaccine at 2 and 6 months. It does not reset to 0 if you don't get that second one at 6 months. It simply means that you're not as fully protected until you get that second shot, but you can get that second shot anytime. So that is not something I would put high on the sort of priority list at this time.
Thank you. Juliet, we got a question that we've gotten on a lot of the town halls that I think is very important, and that is, can you put your information about end-of-life instructions, your medical decision maker, et cetera, is it possible to do that through Patient Gateway? You're muted.
Here we go. So as with a lot of systems, that's one of the things we're working to improve. It's not possible at this moment, but we're trying to make those forms virtual. So ideally they live at a place where everybody can see them and access them when we need to. And there's different technologies that help to enable that. I would say for right now, if you've done that important work, you can scan it or bring it to your next PCP visit, and we can put it in the electronic medical record so everybody can see it. And as we improve our technology, I think the best way will be to give you even more control so that you can kind of update those pieces of information as you create them and over time through Gateway.
And one other thing I would add to that is that
Yes.
the resources I mentioned earlier, Prepare for Your Care and CAKE, both allow you to document a lot of things like this. And you can either print them out and fax them in to the practice to go into your record, or on CAKE, you can actually, once you complete the information, you can send it to anyone you would like it to go to. So you could send it to your doctor, you could send it to your children, your friends, your medical decision maker, whomever. So there are lots of different ways that you can document things that will make it much easier for the people that are taking care of you if you can't speak for yourself. I got a little bit more, Blair,
Sorry.
go ahead.
I also want to point out that the palliative care team has worked to create sort of workflows where we can virtually do some of this work as well. So if you have strong feelings and you want to have certain things reflected in the chart, even though under normal circumstances, certain forms require the signature of both the physician and the patient, there are workflows that will allow us to work around that to get the information where it needs to be.
I'm going to go back to Bill for this question, and it's clarification about the self-isolating. If you are coming into Boston from somewhere else, how long do you need to self-isolate? And should you just be doing everything that Governor Baker has been recommending? And a related question is, what about if your grandparents, how much do you need to distance yourself from your grandchildren? That's kind of a tough one.
Sure.
But Bill, could you maybe speak to those?
Sure. Yeah, I will say the recommendations for the coming in from a different state would kind of apply the same kind of 10 to 14 day time period, assuming you're traveling, you know, no matter which way you travel, you're potentially going to be exposed to a number of people along the way, or travel itself is going to be an exposure. So, you know, that time period, if you were exposed at the very last minute before you traveled, waiting 10 to 14 days is going to tell you whether or not you potentially got sick. And if you haven't, it is thought that you have a low likelihood. As I said, we do talk about this asymptomatic shedding, but it doesn't seem to be as prevalent maybe as people are concerned. So I think that would be a safe time period to talk about kind of re-engaging with people who you haven't seen. The grandchildren, once again, would really depend. Kind of often the grandchildren are often about, or maybe not as isolated as you have been. And so that's one of these challenges of who's been exposed to who. If you said in a perfect situation where both groups had seen no one for 2 weeks, that's probably a low risk situation. But once again, if people are coming in and out of the house, if they're traveling out, if they're doing more grocery shopping than you've been doing, then there is more of a risk. We do know that children seem to be more likely to potentially carry the virus without getting particularly ill. It is less likely for younger people to be hospitalized with this virus. It's less likely for them to need medical attention, although the incidence of infection seems to be pretty consistent across age ranges. So it's not that people don't aren't sort of affected by it, but that who ends up getting into medical care seems to skew towards an older population, and well as the severity and the chance of being hospitalized is greatest if you're older.
Bill, I'm going to direct the next question at you because I know you've spent a lot of time taking care of people in the hospital. And it's a question about, can you say a little bit about the survival rates we're seeing in people that need to be intubated, and also whether there's any long-lasting neurological damage from being on a ventilator?
Yeah, that's obviously a tough question to give a sort of figure to, as you might imagine. I guess the main sort of thing I would say, which gets to Juliet's sort of part, is your own kind of health as you're currently sort of at where you are, and what kind of problems you have that might be progressing anyway, really factor into how well people are going to do if in fact they need intensive care and they need to be placed on a ventilator. The survival rates, I don't have an exact number. I will tell you that some news reports have quoted these very high mortality rates for this virus of being in an intensive care unit, 80+%. That is not our experience at all. We have had much lower than that. However, it is more serious, obviously, if you end up on the ventilator. Many of our patients who have been in our ICUs have remained in the ICUs and are getting better, but have not yet left the hospital. And so when you count numbers, often people have not counted the people who are not yet discharged from the hospital. So the exact numbers we may not know for some time. As opposed to long-lasting damage, there is nothing in particular about this virus that is much different from a lot of the other things that people need to be placed on ventilators for, but there are some particular problems we've noticed in supporting people on ventilators where they may need to stay on it a little longer. The longer people are on ventilators, neurologic damage, so to speak, is not a definite sort of expectation, but people will have a lot of weakness from not using their muscles when they've been on a ventilator and they've been supported and not getting out of bed. So they come out having a lot of difficulties swallowing, moving, standing up, and that requires a lot of rehab and therapy, both from our swallowing specialist and our physical therapist along the lines as well. And the longer people are in the hospital, I would say the last part is that it is more likely that you develop a second complication from being in the hospital, whether or not that could be something like another pneumonia, another infection, a stroke, things like that. But I would say for people who make it off the ventilator and make it back onto our regular medical floors, we've seen that they are pretty weak. Sometimes they are a bit confused coming out of that much sedation, but that they gradually recover over a period of a week to 2 weeks with us in the hospital, and then they usually move on to a rehab facility where they can continue to strengthen up.
Thank you. So we only have about 3 minutes left. I'm going to give Bill, you get the last question, and Bill knows I love to torture him. So the last question is, do we have a position on routine testing for people that are in the essential worker category at MGH?
We do not have a official position and testing. I think, as I said before, the challenge with these type of strategies really are going to be just how one is confidence in the test, as I said before. So the antibody test, we don't have a lot of confidence in right now and what it means to have a positive antibody test. And then the virus test is not entirely sensitive to picking up illness, so it can miss some things. It's also hard to do. And now we're developing sort of more rapid testing of just swabbing the front part of the nose or the cheek and things like that. So those would be more able to be rolled out in sort of a mass screening way. But how often would you do it? How often would you expect people need to be screened? These would be all the challenges in trying to establish that kind of policy for people who are being exposed. So I think that's why probably for the near future, you're still going to see a lot of the recommendations for mask wearing and social distancing are going to continue for the near future for certain.
Thank you. And Blair, thank you for answering the question about our dental care. And I'm going to turn it over to you to say goodbye to everyone. And I have just a quick closing remark after you. So Blair, it's over to you.
Okay, great. Well, I'll just say what I wrote in the thing in case people didn't, in the chat, in case people didn't see it. I assume our dental clinic will open up gradually along with the rest of ambulatory, but one of our docs saw an article in the newspaper about something called Dental Cupid, which will tell you, you can put in your zip code and it will tell you about dentists who are open in your area if you have an urgent dental need. So thank you so much to all of you for joining us. And I'll leave it to Susan to say whether we're going to be doing more of these by team. It really is nice to have the opportunity to answer questions because we know there's so much uncertainty out there. And we also know that there's just so much information traveling via news and internet, some of which is good and some of which isn't. So we really appreciate your taking the time to join us to hear what we have to say. And stay safe.
Thank you. And yes, we are definitely going to be offering more of these for the rest of the IMA and actually our other primary care practices. I also just want to quickly thank a lot of the people that helped us with the behind the scenes work. Pat Gavin, Kelly Spinelli, Mia Hashimoto, and also Jen Searle Como and Abby Vigneron, who helped us find all your emails so that we could invite you. So we really, really appreciate your help. And I also want to underscore what Blair said, because I think one of the reasons we've learned these town halls are so important is because this is such a time of uncertainty. And it's also the fastest I've ever seen medical science and evidence change, so that what we say on Monday, we may have knowledge on Tuesday that is completely different. So I have now a new favorite quote that's an Arabic proverb. Those who pretend to know the future lie, even if they accidentally speak the truth. So with that, I think we will say goodbye and wish you all the best of health. And please let us know if you have other questions. The other thing I want to mention is that we have recorded this, not you, but just the speakers. And we will be sending out the audio recording to everyone that we initially invited to attend today. And that's also something that if it's helpful, please feel free to share it with your friends and family. So thank you very much. I hope you have a great rest of your day. And thanks to all of our wonderful speakers.
Hey, seeing everyone.
Take care. Bye-bye.